Right, so this is about deprescribing. Right, who am I? For those who haven't met me before, I am Stuart Hutchinson. I'm a geriatrician here. I work in the community quite a lot. I am exceedingly local. I was born at West Park Hospital, and like all good Wolvo boys, have found my way back there. For those of you who are not educated, that is the local demigod, Steve Bull. The only good thing to ever come out of West Bromwich. One club, 306 goals, amazing. And if you think I look like other people, well, there it is. If I was going to be politically incorrect, the old one out is probably Father Christmas, in that he's the only person who's never had anything to say about end-of-life issues. Yeah, work that one out. So what am I talking about? So let's take an example. What I want you to do is to close your eyes and go to a happy place. And I want you to just think about Mrs. A. And Mrs. A is 84, and she's had a previous MI more than a year ago. She's got type 2 diabetes, she's got osteoarthritis, she's got COPD with an FE1 of 60%, and she is depressed. You make it osteoarthritis of the knees for a bit of extra input. What do the NICE guidelines say that she should be on as a minimum drug? Oh, first of all, just think of your Mrs. A. What came to mind? Now, my Mrs. A is a lady who comes from Bilston. For some reason, she is dressed in black. She has a BMI of 30, i.e. largely spherical. She has dark hair with grey roots showing, and she is coming back on the pavement from bingo with a stick. That's my Mrs. A. Other Mrs. A's are available. Your Mrs. A may be doing something different. But anyway, what does NICE say that this lady should be on as a minimum drug set? Suggestions, please. Nothing. I'm going to have to start picking on people. You'd be dead right, Amy. Well, I did take you through the prescribing course. You get the easy one. What's the first one? A salbutamol inhaler. The respiratory crew up the back. Aspirin. Random pharmacy rep. Sorry? Statin. That all? Paracetamol, probably. Codeine, hold that, probably not. Not as a baseline, but certainly it's not improbable. ACE inhibitor, 5. Beta blocker, 6. Cetraben? Sertraline, SSRI antidepressant, yeah, 7. Metformin, 8. Did we have aspirin before? Yeah, we did. Probably 1. It's more than a year ago, so she can get away with 1. That's why that's 1 in there, but it's possible. Second inhaler. Now, when this was done, it would have been a LABA, but frankly, they changed so much. Another inhaler, including the all-in-one triple inhaler, would now probably be an approaching standard. Respiratory team, don't judge me. OA knee. Specifically OA knee. Not a tablet. Yes, you could, but not every day.
Ibuprofen gel.
Ibuprofen gel. Okay. We got the... Oh, don't forget the omeprazole to cover the aspirin. I came up with those. Those are the ones. Salmeterol, this was actually a medical student paper from about 2011. So, I don't know, LAMA, combined LABA, steroid inhaler, they're kind of all in there. That is the minimum set. So we've already had her jabbed with steroids. We've already had her Someone's chucked the opiates on. It's not unreasonable, it's just not baseline. So, cast your net more widely. What else could she be on for those diagnoses? The elderly care department got up to a total of 25 meds. Sorry, was that for you? Were you going to say something? No?
Codeine.
Codeine we've got, yep.
Gliclazide.
Ooh, gliclazide. Old school. Yep. No. Okay, we came up with, oops, that's the original one. We came up with several. We went in for gliptins, exenatide, insulin opiates, steroid injections, tiotropium, combination steroid LABA, or indeed this new triple thingy, amlodipine, alpha blocker, spironolactone. Yeah, as I say, we got up to 25. I think we also chucked in some gabapentin to make her feel happy and get rid of a neuropathy, and, well, it was painful and nothing else worked. If you stretch it that far, you can get to some real kind of high functioning stuff. You get real large numbers, up to 25. But actually then you then have to ask, what about the function? Now my Mrs. A actually is pretty functional. She's walking down the street, she has an independent life, she's doing all right. But at 84, she's probably at the top end of functioning. Probably the top end of life expectancy. Actually, as I go around, an 84-year-old could now be in a nursing home, bedbound, doubly incontinent, swallowing difficulties, with dementia to the extent they can't recognise the family. Is that person still subject to the same guidelines? And the actual drug choice there was kind of put in on the basis of people who it was taking the individual NICE guidelines and sort of putting them together. The multimorbidity guidelines basically just say, yeah, kind of have regard to the fact that polypharmacy happens, and you need to do something about it and think about it. So, as I spend a lot of my time in nursing homes, I thought I would a few facts, because this is where the frailest people go for the end of their days in the most part. They are 20% of people will end their lives in a nursing home, and if you happen to be over 65 with dementia, it's somewhere between 50 and 60%, depending on which part of the country you actually live in. Dementia is the commonest reason to go in. What proportion of women can expect to enter a care home, so residential and nursing at some point? It's 1 in 3. Blokes, it's slightly lower odds. Blokes tend to marry younger women and then die first. That's not a value judgment, that's a statistical observation before the sisterhood take me outside and teach me the error of their ways. How many care home places are there in the UK? Actually about 500,000. It's a stack of capacity in about 100,000 nursing home beds. It varies. Actually, in contrast to what you might think, that number is going down. People are staying in their own homes longer, we're helping them into their own homes longer, and actually it has become progressively more difficult to run the places at any sort of profit. Average age of the residents, 88. Now, median life expectancy in nursing care, 10 months. In other words, if you go into a nursing home, 100 people go into a nursing home, 50 of them will be dead within 10 months. Mean is 12 months. In other words, it's a skewed curve with a bit of a tail. 30 months for residential care. So, with Claire here, the palliative care question, for just about anyone in a nursing home, would you be surprised if this person died in the next 12 months? The answer pretty much is no, you would not be surprised if they died in the next 12 months. Which takes you off into GSF, end of life care planning, the My Care document that's just been launched, free plug, use it, it's good. But we're sticking with the meds aspect of palliative care for the next half hour or so. If you want to look at it from a frailty point of view, this is the electronic frailty index. For any GP trainees out there, your EMIS system will calculate this for you free of charge. And if you hit an electronic frailty index of 0.6, you are certainly, almost as certainly going to die in the next year. The problem is that what it takes to get an EFI of 0.6 is pretty, it's about 3% of your total elderly population. And indeed, when we were doing some meds reviews in a nursing home, all of them counted as moderately frail, which is about 0.3. And that was kind of standard nursing home dependency and cognition. I've put this one in really more for aesthetic appeal than anything else. Basically, this is a gorgeous way of just putting in pretty colours that the older the older you are and the more frail you are, the more likely you are to die. Whoever knew? But there you have it in some form of science, but put in a particularly aesthetically pleasing form. And then there's also the how of deterioration for this group. The entire how of deterioration for the frail is often, if they die, it'll be because they fade, they stop eating and drinking, they get less mobile, they lose weight and go out that way. Or at some point they get a pneumonia or some form of clanking sepsis and go that way. And if you actually think about the people who you write death certificates from 24-hour care, a lot of it will either be 1A frailty of old age or 1A bronchopneumonia secondary to 1B immobility, 1C dementia or frailty of old age. Actually, if you think about the death certificates that you write, and I've tested this on GPs as well, the classic chronic conditions, so LVF, COPD, diabetes, will actually turn up in part 2. In other words, they were kind of around, but not necessarily causing all that much symptomatic problems at the end of life. Of course, there are exceptions to this. It doesn't work for everyone. But it seems to me that's pretty much the way it is. And if you look, dementia as a cause of death has gone up the causes of death, partly because we're more likely to write it in, but partly because that's how it is. And ethically, and ethics, I like ethics, there is no difference between not starting something and stopping it once it's been started. As medics, it feels a bit different. Once someone's on something, it takes a heck of a lot more effort to stop it. Or, to put it another way, if you're looking at someone and you're thinking of stopping something, ask, if they weren't on it already, would I really be writing it up? The little old lady who had her MI 10 or 15 years ago, the 90-year-old who's now got dementia and is bedbound, but isn't on the statin, well, would you be writing it up? Because if you wouldn't be writing it up, then effectively you're leaving them off it anyway. Which turns to the question of, but won't they die if we stop all the medications? Well, as we've seen, actually, they're going to die pretty soon anyway. And of things that aren't related to what you're giving the tablets for. And increasingly, there's a really... I thought I'd edited this before I came out, I clearly didn't. For those of you, for the elderly care population, the Age and Ageing Journal, there was a really good leader on deprescribing, which was Evidence of the Geriatrician's Scalpel, which is a great title, apart from the fact you wouldn't want me near you with a scalpel, or anyone else for that matter. Evidence is in non-randomised studies that people actually live longer if you do deprescribing, and actually if you randomise people, they certainly don't die any quicker. Yes, things might happen, they might have that stroke, they might have that heart attack that kills them, but actually at this point, partly it seems not to make any difference if you apply it to large populations. And the other thing, of course, is that the population you're giving it to, the frail and the multimorbid, are so far outside of the remit of study populations that you don't know whether it's working or making any difference anyway. This is my, every elderly care consultant I think has one of these on the go. This was taken by the Falls nurse when I worked at City Hospital Birmingham, and it's again, it's a thoroughly aesthetically pleasing set of meds. The pharmacists in the room will be falling into two camps. One group will be trying to identify what the tablets are. The other group will be looking somewhere over here and asking themselves, isn't that a Dissect box? And they'd be right. This was actually this lady's second attempt at this. On the first time, she'd simply taken all the boxes of meds and tipped them in and given them a good shake. The second time, she'd gone to the effort of going round all the Dissect boxes and popping them out and chucking them in the sweetie jar. And she'd just take a handful when she felt like it. Compliance, concordance, whatever you call it, is not a particularly... it's not a great thing out there. So, I mean, occasionally she'd come in dehydrated if there were a few too many diuretics. If hypertensives were a problem, she'd fall over. And occasionally electrolytes became a big problem as well. Or the tachycardia. I think the blue ones are amitriptyline, which is a bit sus. Nonetheless, there you are. This was a lady who it didn't particularly work out all that well with. And then there's the pharmacy angle. Richard is a pharmacist who I worked with in my Sandwell days, who's a great mate, and he came up with the quote, "That's the difference between you and me, Stuart. I would start everything because that's what the guidelines say for individual conditions, and then you'd come along and stop it again." And I suspect in a microcosm there you have the difference between pharmacists and medics. Pharmacists, I love you all. You've all got OCD. My sister's a pharmacist. She got all our family's OCD genes, and I love her dearly. I also go around every Wednesday afternoon with 3 pharmacists who teach me an absolute shed load of stuff. So I'm seriously quite deeply indebted to them. So what are the principles of prescribing for this group? What are the principles of prescribing when you get to this degree of frailty? One is that not all tablets are bad. Secondly is only giving what people need. Because actually if they've got limited concordance anyway, then giving them a fewer more effective tablets is much, much better than giving them absolutely shed loads of stuff that you don't really know what the heck's working. 2, if you're going to continue stuff, it should be the stuff that treats symptoms that matter to the person. Not just stuff that prolongs life, not just stuff that's purely the evidence is about prolonging life. And also, and again, this is where the experience with pharmacists is that some things are mighty difficult to give. So, again, audience involvement. Who here has tasted Sandoz-K? Who here has prescribed Sandoz-K at any point? Lots of hands go up. Think back to GCSE medicine, people. Potassium is in the same group as sodium. You might as well give them some seawater. I mean, apart from that, the seawater's got sodium, not potassium. It tastes the same. Okay, who here has prescribed Adcal or Calphavit? Keep your hands up if you've ever munched your way through an Adcal. And the tumbleweed came across. And my third one. Who here has prescribed Fortisips? Quite a few people. Who here has actually swallowed a slightly warmed butterscotch Fortisip? Or Tutti Frutti or chocolate? Yay! And it's the geriatrician in the room. I salute you, Phil. They just taste nasty. I won't ask who's munched their way through a metformin pill because you really shouldn't be doing that, but they are problems. So to take it forward from the kind of the theoretical underpinnings, are there guidelines out there? Yes, there are. There are things called the STOP guidelines, S-T-O-P-P. They are useful, but really I think quite limited, and it's a bit like don't give long-term non-steroidals to people with renal disease. Whoever knew? Actually, the better ones, and I think it's something that we'd kind of worked out independently, there's something called the Stop Frail prescribing guidelines, which is pretty much agrees with what I'm about to go through. But it's it's a bit more codified, it's a bit more thought out, and it's a bit more evidence-based than I've got. So statins. Statins only work for secondary prevention. And even then, if you're in your last year of life, think hard about it then. Aspirin and clopidogrel only. If you think that really, there's still 1 or 2 people who've got it when everyone over the age of 55 with diabetes got given aspirin and hasn't been stopped yet. But pretty much if it's primary prevention, you shouldn't be using aspirin and clopidogrel. And of course, not in AF. Anti-anginals. Now, particularly with your frail population, if you think about it, anti-anginals, and I'm particularly thinking of nitrates here, you actually need to do something to get an angina attack. If you've got someone who's immobile or bedbound, they're just not moving. Don't give it to them. Doesn't work. Warfarin and DOACs, I think, are a really interesting case. Yeah, they're reasonably effective in study populations, and if you do all your CHA-2DS2-VASc is your risk score for having a stroke in AF, and it's good, and HAS-BLED is your risk of bleeding, and somehow it's been set up never quite to come up to the same level as CHA-2DS2-VASc. That you are achieving some degree of life prolongation, possibly. I personally think we're going to see a big step change when rivaroxaban comes off patent and becomes about £3 a month like everything else. Okay, all you prescribers, who's going to tell me how much rivaroxaban costs a month, by the way? About 28? That's what it's down to now. It started off at 54, so it probably has come down. So I think when that becomes generic, and everyone's on it more than they are at the moment, but I think at the moment people are so kind of invested into anticoagulation, and I think that people think that because warfarin, you get blood tests and it has to be dose adjusted. It's a kind of a big investment. So we tend to keep people on, possibly when the benefits aren't all that obvious. Cardiology, ACEs and ARBs. Probably no role in blood pressure control unless it's very poorly controlled. Interestingly, there's evidence that actually blood pressure tends to go down in the last year of life, and we did a separate audit where we stopped 20 people's antihypertensives and about 2 of them had to go back on. I personally use bisoprolol rather than digoxin in this group. The only good reason to give digoxin, particularly in nursing homes, is that someone will take a pulse every day, which they don't seem to do with bisoprolol. Nice guidelines are that everyone should have an AV node control, so bisoprolol, diltiazem, verapamil rather than digoxin, and digoxin should be reserved for those who are totally immobile. Because if you didn't know, if you exercise on digoxin, it's a bit like it doesn't exist. Your pulse just goes up into the 150s, 160s. Having said that, as a group, the frail are more prone to dehydration. They've got dodgy kidneys, so actually they're more at risk of dig poisoning anyway, which makes them feel off. So these days I pretty well start on everyone on bisoprolol unless there's a good going contraindication. Bottom right, tattoo from an 84-year-old nurse. It's definitely a form of advanced care planning. Whether it actually qualifies as an advanced directive, I think not. But I do think there is a gap in the market for a lawyer with tattoo skills for actually tattooing a legally binding advanced directive. I'm just putting it out there. Diuretics. Diuretics are great. The problem is that when you get to looking at a lot of the people who I'm looking at, is that the reason for starting these medications is often lost in the mists of time. So certainly in the early days of nursing home work, and this goes back 12 years ago when we were kind of the only people going out there, just about everyone was on Bendro for swollen ankles. As a really famous professor of geriatrics, a guy called James Young, and he came up with the hypothesis that basically if you are immobile and you do not have swollen ankles, then you're probably dehydrated. think about it. Most of the people have got venous insufficiency. You're not using your calf pump to get back enough. You're sat in a chair all day if you're not in bed. You're gonna get swollen ankle. Oh, and you're in a home with the heating turned up to furnace. You're gonna get swollen ankles. Having said that, if you stop them for swollen ankles, you really have just got to make sure that they haven't got a diagnosis of proper good going congestive cardiac failure, fluid up midway up here, or indeed symptomatic left ventricular failure. Because if you stop those, they'll go back into left ventricular failure and they'll get admitted, and you'll have done the wrong thing. Again, it's swollen ankles is about symptom control. Hypertension is about long-term prognosis. Failure, actually, diuretics are treating symptoms, and that therefore a good thing to be continued. Respiratory. Now this one's quite interesting, particularly when you get to the end of life with people who are less mobile. All the inhalers we give, and I think I've checked this out correctly, the inhalers we give are really more about maximising function than they are about actually changing prognosis. So if you think about it, if shortness of breath from your COPD is actually your limiting factor when it comes to exercise, fine, keep the inhalers going. If you are so immobile that you're not doing enough to get shorter breath, again it's the angina principle, then actually what good are those inhalers doing? And there's some good evidence from Steve Allen, again a geriatrician in Bournemouth, who said that really by the time you get to an old-fashioned mental test score of 7 out of 10, so moderate cognitive impairment, then you probably can't use a standard metered dose inhaler. In fact, a third of the population can't anyway. A third of you in this room, the educated and the greater than good, probably can't coordinate a standard metered dose inhaler. If you get down to 4 out of 10, then nearly any form of inhaler, certainly they won't be able to use on their own at home. They'll have to have something given to them. So then you kind of get to that point, and sometimes it's about asking the carers, sometimes it's about testing how people use their inhalers. Basically, if they're not using their inhaler properly and haven't been for some time but aren't complaining of being short of breath, then actually that inhaler is not doing any good. And what you don't need is an alternative delivery device. What you need to do is stop it. And actually some of the combination inhalers don't work out cheap. Each Seretide inhaler is about 35 quid a throw. Cheaper alternatives are in the mid-high 20s. So that's about 300 quid a year that's getting cheerily sprayed into the atmosphere every time you prescribe one. So what do we do? Basically, for a lot of these people, what they do need is a salbutamol metered dose inhaler, cheap, plus some form of spacer device, usually an air chamber these days. If they're persistently short of breath, if they're persistently getting problems, then these days I have a lower threshold for giving nebulizers and low-dose oral prednisolone, 5 or 7.5 milligrams a day. Actually, I've got 1 or 2 people in the community who I've kept on that probably for a couple of years and haven't had an exacerbation during that time. Again, it comes down to the life expectancies that actually these people are going to be dead long before they have enough steroids on board to give them osteoporosis. And at the bottom, my favourite, carbamazepine is basically expensive cough medicine. Yes, you can add it on as the final stage of COPD management before steroids, but the best I could give was when I kind of nailed a respiratory SPR to the wall, and they said the number needed to treat for carbamazepine in chronic use is well over 100. In other words, 99% of people, it is going to make no difference for long-term use. The problem is that it's kind of given because it's licensed for it, and people like things for coughs. I worked with a GP when I was a student, way back in the day when you could say these things. I worked with a GP, and he would tell people who would come in saying, I want something for my cough acutely. He'd say, well, The cough reflex is one of the last things to go before you die. So me trying to take it away with some nice tasting syrup just isn't going to work. I'm not totally sure you could get away with that in primary care these days. You know, take the cough syrup if you think it tastes nice, by all means. Just don't expect it to work. Yeah, that's basically the same thing said in another way. Gastro. PPIs. There's a lot of them out there. They're sort of reasonably safe. The problem is that so many people are on them that every single side effect has now been kind of multiplied so many times. So all the hypomagnesemia, all the hyponatremia associated with diuretics is just amplified. Never mind the doubling the risk of C. diff and the osteoporosis risk that seems to come with them. And again, trying to find them out trying to find out who gave it and why can be a major problem. And our team, our shorthand is, this appears to be a bog-off PPI. What is a bog-off PPI? A bog-off PPI is the PPI that was given with the aspirin and clopidogrel. Buy one aspirin, get one omeprazole free. So when do you continue them? I would say always with a PEG, because it's a foreign body in the stomach. They're prone to vomiting and they've all got gastritis because of the PEG bumper. Long term with GI bleeds, if you've had a significant proper ulcer, yeah, over the age of 65, you're probably still needed. Lowest dose. Omeprazole 10 and lansoprazole 50 will do just fine, thank you very, very much. And to an extent, care stopping in other situations. Some people will have had nasty reflux, and if you've got any acid producing cells left, they will spring into activity once they're unsuppressed. So you can get a rebound in symptoms when you stop. But again, it's another tablet. It needs to be thought of. Lactulose, in my humble opinion, has no place outside of GI wards. And if my life's work has been to decrease its use, then I have not been qualified 30 years totally in vain. Why lactulose? Well, tastes syrupy, takes 48 hours to act, gives you gripey abdominal pain, makes you fart, and then gives you nasty sticky poo. Apart from that, what's not to like? Laxido these days is pretty much the default. You can go up to the nuclear option of 8 sachets in a litre of fluid. Drink until something happens. It's in the BNF, don't knock it. And something will indeed happen unless you've actually missed a bowel obstruction. Often quite dramatically. Urinary. Anticholinergics in the always incontinent. If they're still making it, if they've got urinary urge and they're on anticholinergics and they're making it to the loo in time, absolutely fine. By the time they're always incontinent and padding up, all you're basically doing is giving them anticholinergic side effects. Don't work. And also, catheterized patients, stop the tamsulosin, stop the finasteride in blokes. They've got a catheter going through their prostate. It does not make it any more difficult to catheterize them in future. Just get rid. They don't need it. Diabetes. The thing about diabetes is really once you're over the age of 65, tight control probably, as measured by HbA1c, is probably not that much of an effect in your long-term prognosis. You're looking for symptom control. You're making sure they're not getting hypos. You're making sure they've not got polyuria and polydipsia from that degree of symptoms. Also, that intake can be erratic. If you're looking at long-term control, an HbA1c below 8.5% in old money, whatever that is in 75 odd something. Someone can convert it into whatever they've changed HbA1c to. Specific therapies, metformin, weight loss, nausea, diarrhea. Again, if you're at the end of life, that's not what you need when weight loss is frequently a problem anyway, you're really looking at maximising the food intake. Had a good one of those in the community only last week where someone had put the metformin up to 500 TDS and the lady just threw up everywhere and couldn't get off the loo. Sulfonylureas, so whoever said gliclazide and glimepiride, well, okay. Hypos and weight gain. The weight gain is probably not such a problem in this group, but the hypos certainly are. And for insulin, if you think about it, we either end up giving basal boluses, so glargine and Novorapid as short-term fixes, or we end up with fixed combinations, something like Humalog, so 75% intermediate, 25% short-acting. The problem is with that is frequently in frailty, and particularly in dementia and frailty, you've got a group whose intake is fairly erratic. And if you're giving a fixed dose insulin, then twice a day you're giving them this big spike of short-acting insulin that isn't going to do much for their control, but most certainly will increase their risk of hypos. So for preference, I would probably use Insulatard, which is just an intermediate-acting insulin. Or Glargine if you think you're going to get away with a once-a-day insulin. And the diabetic team largely have run this by them and they agree. Mental health. The health warning, I think. If old age or psychiatry are involved and you see a whole bunch of mental health medications, move away. There's nothing to see here. You're just going to make things worse. But for the rest of us, if the psychiatrists aren't involved, antidepressants, particularly in frailty and even more so in dementia, are a problem. Dementia and depression coexist, no doubt about it, and it's a big problem. The bigger problem is that there's a big study that says that SSRIs and mirtazapine don't work for depression and dementia. In other words, they're pretty well inert and they shouldn't be given. And it's then into the, well, if we stop it, won't they go downhill still further? But yes, they've got a degenerative condition anyway. And it's then trying to go back and untying, actually, why were these things given? And if you think about it in the history of dementia, particularly if you blow your frontal lobes out first, one of the things that comes in is apathy. Yeah, mum's got some dementia, but she stopped going out. She stopped changing the TV channel. Well, that's actually because the dementia has made her unable to. She's not depressed, she just can't do it. She's just sat in the chair because there isn't a new thought coming in to tell her to do anything else. Sleepers. So, Zopiclone, Zolpidem, increasingly melatonin, because it's natural in it. Historically, temazepam, barbiturates, chloral hydrate. Mankind has craved a good night's sleep. None of them work very well. Some of them only get you off to sleep for 1 to 2 hours. All of them have tolerance. All of them have dependence. Or to look at it another way, and this is from a talk on delirium, there is no tablet that will make your person put their head down on the pillow at 11 o'clock and wake up 8 hours with uninterrupted sleep. Other things like sleep hygiene may play a part. Tablets don't. Antipsychotics used to be a really big problem. They're now less of a problem. I think we use them judiciously where the risks of behaviour outweigh the risks of not giving them. So it's the person who's kind of psychotic, who's got the psychotic symptoms, who clearly has the EBGBs, who's scared out of their brains. Donepezil, and for that matter galantamine and rivastigmine, if the mini-mental's patently under 10, in other words you go up to them, hello, what's your name, and you don't get anything back, you can actually stop them. Because it's only licensed, Donepezil, galantamine, rivastigmine are only licensed down to a mini-mental of 10. Below that you can stop them without problems. Memantine is a drug that was initially licensed for memory problems in dementia, but seems to have crept over to be a drug that treats behavioural problems. It is licensed down to a mini-mental score of 0. In other words, you can't use advanced dementia as a reason to stop it. But again, it's probably not doing a great deal either at this point. Sometimes you just have to trial stop something for a couple of weeks and say, well, 90% says it's going to be all right, it's not doing them any good. 10% says that they might rebound. And then there's the bits and pieces. Right, thiamine, vitamin B co-strong. Vitamin B co-strong doesn't have a place, should be stopped. That's been the case for about the last 2 years, but you'll still find people on it. Thiamine. If you are not taking a purely liquid, i.e. alcohol diet, and you're getting some form of reasonable intake, you will be replete with thiamine after 28 days of tablets. And that is the case for most things. If you have a Wernicke's encephalopathy, in other words, the full-blown acute confusion, altered eye movements, the acute confusion bit, you probably need it for a couple of years. If you have an alcohol-related dementia, then it's probably 28 days. It's probably hugely overprescribed, and people stay on it for far too long. 28 days seems about right if people are eating and drinking and not going off. Again, in an establishment, you've got control. At home, if they're at home and still drinking, something is probably better than nothing. But again, compliance is not going to be fantastic. Iron, when we were going around the nursing homes, you didn't need to look at the history to see whether someone had a fractured neck of femur. You just look for the iron. If they're on iron 3 times a day, they'd haven't fractured neck of femur, TNO had sent them out and no one had ever stopped it afterwards. Well worth rechecking. Folate is a really interesting one. The blood test for folate is variable day on day depending on what you've eaten and 1 or 2 other factors. I think also in the frail elderly, particularly at home, it's just a measure they're not eating particularly well. And actually thinking about it, the number of people with a low folate who have had either a macrocytic anemia or a peripheral neuropathy is exceedingly low. And I have it on good authority, there has never been a single case of folate deficiency that's caused a dementia that's then been reversed by giving folate. Just doesn't happen. Basically folate, 3 or 4 months, stop it. If you give it at all. It's not hugely expensive, but it's another tablet. Calcium and vitamin D, the traditional version of this talk was, by the time people get immobile, stop it, because if you're immobile and bedbound, you've probably got nowhere to fall and break stuff. And it's difficult to give if you're immobile and lying flat. And yeah, as I said earlier, basically having AdCal is like trying to chew your way through a cliff. Drinking a Calphavit is like drinking mud. Calphavit is a dissolvable form. And then someone came out with the meta-analysis about 3 or 4 weeks ago that said we really should be more careful about who we're giving this stuff to. In other words, blanketly giving it to people who are immobile or in res or nursing care is out the window. And as far as I could read those guidelines, and they were a bit nebulous, or it was a meta-analysis, it basically says only give vitamin D to people who are vitamin D deficient. In other words, lots of vitamin D tests, replace those who are deficient, don't replace those who aren't. It didn't say who was deficient or not. The meta-analysis was not that detailed, and it didn't go into great depth over who or who shouldn't. I suspect there is a rheumatologist or an endocrinologist who could probably give a better talk on that, but that's my reading of it. Vitamin B12 tablets. Now the standard ones are 50 micrograms. Oral vitamin B12, there is one study that says that oral replacement works, and it comes from Scandinavia in 1991, and it used 1 milligram tablets. So you can either give them 50 cobalamin 50 mic tablets, or send them off to Holland and Barrett, where you can get them for about £3 a bucket. And even then, you've got to check whether it works. And frankly, if I've got a macrocytic anemia or a peripheral neuropathy, I'd take the injections. And then 40 sip, 40 creme, 40 juice, 40 something or other. There's no magic in these. They're made out of where basically they're made out of fat and artificial flavourings as far as I can make out, and they taste foul. They are also meal supplements. In other words, you don't put them there because they're just easy to suck from or sip from, that you use as meal replacements, as I've seen given. And actually it's no better than stuff that tastes nice but is high calorie. So food fortification wherever possible, please. The other thing is that while they cost about 2p a go in hospital, in the community they cost these days about £2 and 5p, £2 and 7p each. So if you multiply that up, that's actually about 750 quid a year, and that's one bottle of 40 sip a day. You can get an awful lot of good food for that amount. And of course, if you're giving 3 a day, it's well over 2,000 quid. That's a heck of a budget. Also traded in some less reputable parts of Wolverhampton for drugs and other nefarious substances. Yeah. Then Wolverhampton oddments. Occasionally, particularly when someone's changed location, we have found at least 2 people who've been on methotrexate and had no monitoring for over a year. This was scary. And then buprenorphine patches. Now, I have a bit of a love-hate relationship with these things. You can slap them on once a week. Nurses love them because it's 1 CD every 7 days, not 2 CDs a day like morphine tablets are. And certainly in frailty, and particularly in dementia, there's a narrative that goes, well, pain is a source of agitation, so we put the buprenorphine patch on and they stop being agitated. Therefore, the pain must have got better. Yeah, pain relief and near anaesthesia will actually look much the same, and both will send your patient quiet. Oh, and the other thing is, if you're going to put someone on buprenorphine or a fentanyl patch, do counsel them about going into hot showers, because they cause vasodilation and enhanced absorption, falls, respiratory arrest, death. Yeah, I have a tricky relationship with buprenorphine patches. I think I've just probably stopped 1 or 2 too many or seen too many go wrong after they've been increased just a little bit far in the elderly. And then there's administration, big pills. Adcal are big, metformin are huge, metformin are horse pills. Multiple tablets, expensive liquids. When we go and do our reviews in nursing homes, the single biggest hit we had was something no more complicated than bumetanide liquid. Bumetanide, perfectly harmless loop diuretic. Someone was on 2 mg twice a day of bumetanide liquid. The cost, as we danced around the room celebrating, was 8,000 quid a year. Some liquids are hugely expensive. How much do we actually save? So say I go around an afternoon a week, you'll find me in Wolverhampton's residential and nursing homes with 3 absolutely brilliant pharmacists who have taught me much. And every year for the past 5 years we've saved 100,000 quid off Wolverhampton's drug bill just from that one afternoon. I thought we'd do it for a year, tell the GPs and they'd get hold of our tricks and follow it afterwards. Actually they haven't. So, yeah, we're still there, we're still travelling around, still doing our thing. It's great, it's more or less a job for life. And also on average, we achieve a 25% reduction in pill count and decreased wastage. So increasingly we've got the home saying, when are you coming back? It's been a year, over half of our population have died. We've got a new batch in with the same problems. When are you coming back, please? So back to Mrs. A. If Mrs. A is in a nursing home and she's, pretty ill and in her last days of life, this is Mrs. A with her MI, her COPD, her OA, her depression. What would we leave her on? I think we'd leave a salbutamol and a space around the place on an as required basis. we'd probably give her some paracetamol from pain control, and certainly give her an NSAID gel to rub into her knee. But the aspirin's gone because she's nearing end of life, and with it the omeprazole went as well. She's sufficiently immobile that the salmeterol isn't going to make any difference to her exercise tolerance, so that went. Lisinopril, atorvastatin and bisoprolol, yeah, they're secondary prevention, but what are they preventing? Not much. Metformin, maybe if a BMI is high and her sugars are causing you problems. Citalopram, probably not, but if it's pre-existing we might. So you can see how that 10, maybe 20 actually comes down, condenses down to two or three main medications. This is a pharmacy special. I'm not sure I'm supposed to know about this, but I do. This is a group, the Newt Guidelines, and you can only get them into them with a password, unfortunately, are a set of guidelines from a set of pharmacists in Wrexham. And they basically found out all the off-license ways that you can dissolve, crush, do things with tablets and capsules to avoid having to get special liquids. I know Pharmacy here have got the password. It's a really, really useful resource for people who can't have trouble swallowing tablets, or where the tablets are difficult to get hold of from other places. Finally, that's the, just to make you jealous, that's the spring view from the back of Hutchinson Acres. The mist is down, and it proves that even the Sandwell Valley can look pretty when it's obscured by fog. Thank you.